All right. Well, great. Thank you so much. Um, I want to thank the Multiple Sclerosis Foundation for allowing me to do a presentation today. It's always an honor and a pleasure to talk about topics that maybe your providers can't talk about because they either don't have the time or the expertise. So I'm going to talk to you a little bit about maybe some of the behind the scenes of MS care. But I want to start out, first of all, by letting you all know that I don't have any personal or financial conflicts of interest. I don't speak for anybody else. And other than wanting to be on this beach right now, that's the only conflict I have. So, the first thing that I thought I would cover really is going to be geared towards patients who have been recently or newly diagnosed, or patients who have been diagnosed and they're just a little bit of uncertain about how an MS center and MS providers go about establishing a treatment for an MS patient. So the first thing that our residents and our attending neurologists do. And we are an academic medical center. So I have 16 residents that are in training right now for neurology. So these young folks are the ones, in addition to our two attending doctors, that are diagnosing patients many times in the hospital with an initial diagnosis and initial occurrence, and then many times patients come to us for our expertise. So I'd like to start at the diagnosis itself. You've been diagnosed, and for a person who, let's say, has symptoms, ends up in the hospital, you've had all this testing done, you're in a hospital bed, your family's around you, and a doctor walks in, or a group of doctors walk in, and they tell you you have multiple sclerosis. So first, oh geez, what happened there? Okay. So the first thing that a patient goes through is the actual processing of the diagnosis. And, I'm in my 60s. So when I was younger, I knew a person, one of my friends, his mom had multiple sclerosis. And when you thought of MS, you thought of an actress by the name of Annette Funicello, and she was in a wheelchair. And so you thought that everybody that had MS was going to end up in a wheelchair. Or you look at, Law and Order episodes where one of the detectives' wives has multiple sclerosis, and they make it out to be you know, a very significant disease. So the first step in the treatment of is the diagnosis. So in our case, we make sure that we verify that the person has multiple sclerosis. That's done through the history, it's done through the MRI findings, it's done through sometimes lumbar puncture. But by far the greatest percentage of patients that have MS have what's called a relapsing form. And the relapsing remitting form is the greatest percentage, probably 80% plus. Now, when I started in the MS profession back in 2008, number 2 and number 3, which are called secondary progressive, both active and non-active, these were classified a little bit differently. We had a classification over a decade ago called progressive relapsing, where we saw patients that had a progressive course, but unlike the primary progressive patients, they had some identifiable relapses. So when we look at the secondary progressive category, these are generally patients that have had relapsing remitting for a long period of time and have hit a phase to where even though they're on drug, they're not getting relapses necessarily, but they're slowly progressing. And then secondary progressive non-active shows really progression without any level of relapse activity. And then the least active, or I would say the least diagnosed percentage, is going to be your primary progressive category. Now, why is that important to know and understand the type of diagnosis? Well, because the treatment regimen, what the patient's going to be given for treatment, is going to depend on that specific diagnosis. So here you are, you have had symptoms, and you end up before a physician or a nurse practitioner or a physician's assistant. You're either in the emergency room or you're in a physician's office, and you've been diagnosed with multiple sclerosis. So I'd like to take you through the steps of how a provider who specializes in MS comes to their conclusions about how to arrive at an appropriate therapy, right? So the first thing we do is we look at the type of MS, and like I said, many times we know this from the MRI presentations and from the history. So let's say, for all intents and purposes, we're dealing with a typical relapsing remitting patient. So if that is the case, which it will be in about 8 out of 10 cases, we're going to look at the aggressiveness of the disease presentation. Now, what does that mean? It means not only looking at the symptoms and the signs, which are actual physical things that we see on examination, but we also look at the MRI findings. And when we see what are called enhancing lesions, which is lesions that are illuminated by a contrast when a patient has MS, that indicates an active inflammatory disease process. So what does that mean? It means that the activity that's going on is within the past 90 days. So when we see MS lesions present, not only in the brain, but in the brainstem, in the spinal cord, in the optic nerve, these present as possibly a more aggressive course than somebody that just might have a couple of lesions in the brain. So the first thing your provider is going to look at is, what type of medication do we need to combat the aggressiveness or the lack of aggressiveness of this patient's condition? Now, the second thing we're going to look at is totally dependent upon the patient's insurance coverage, because every insurance company has a list of medications that they call a formulary. And what that formulary is it's a list of medications that they're going to approve for a specific diagnosis. And in the case of multiple sclerosis, there are some medications on the formulary that are generic versions of medications that have been out for a while. And I'm going to go into a lot greater detail about some of these in just a little while. The main thing I want to stress throughout this presentation is really going to be the experience of your provider. Whether you're a neurologist, is an MD, a DO, whether you have a nurse practitioner that's a DNP, whether you have a PA, whatever your provider's credentials, if they specialize in MS and they are knowledgeable and they treat this on an ongoing, regular basis, their personal experience is really going to come into play when it comes to drug selection and a lot of different factors when it comes to MS care in general. And then the last thing we look at is the patient's input, obviously, and their risk stratification, which means given a certain agent, are there certain risks to their liver, to their, for brain infections, for whatever, is the risk worth taking and is the benefit there for the risk that the drug proposes? Now let's look at some research in MS and how research came about. For those of you that may be new to MS and really don't know a lot about the history, research in multiple sclerosis started back in 1935. And for those of you that aren't my age, we're talking pre-World War II days. So things were a little bit different back then. And what we had were scientists at Rockefeller Institute. They were able to identify a process that was an autoimmune process that they were able to invoke into mice. And this autoimmune form of MS is called EAE. So this mouse model was the basis for the studies of all the platform drugs that were introduced back in the 1990s. And that would include Copaxone, Betaseron, Rebif, and what have you. Okay. And so there are actually 3 different animal models that are used in the study of MS. Now, why is this important? It's important because MS studies have to start in the animal, and then once there's safety and the FDA approves it, then they go on to the human research trials. So these are the rudimentary trials for an agent to start. Okay. Now, the interesting thing is that the first model is done through an autoimmune allergic mechanism. The second model is done through a virus, and it's called Thyler's murine encephalomyelitis, or a TMEV infection. And then the third model is actually a toxin-induced demyelination. So to characterize these, animal models are either forced to have MS through an autoimmune response, through a virus, or through a toxin. So when you think about it, we don't really know what causes MS in humans. And it might even surprise you to know that MS doesn't occur in animals. So it's one of the things that I wanted to point out when you look at how research gets going in MS. Now, in people, we don't understand or know the causative mechanisms for MS. We don't know this. If anybody has been in the MS world for any amount of time, you have heard variations of every one of these forms of how these are induced. So some people feel it's, well, we know it's autoimmune for sure. We don't know if there's a virus involved because many patients with MS have Epstein-Barr virus, but some don't. And then the third thing is we do feel that there could be a toxin-induced mechanism if a person's lived somewhere geographically. So not knowing what the causative mechanism is in humans, really the research trials I think that are most valuable are the human ones when patients have been on drug for a while. Now, another thing that I'm going to point out to you too is that when you look at research trials and you pick any of the disease modifying drugs, they're only compared to one other drug. Okay. And so, and if you're not on that drug that the person who wants to switch you to drug B, and you're on a different drug than it was researched against, then you're using your provider's experience more than you're using the research data to make a decision as to what medication may be better for you. So does multiple sclerosis occur in animals? It doesn't. It actually doesn't. And it develops exclusively in humans. Non-primates are actually resistant to MS. So highly susceptible to the MS animal model. So what does that mean? It means that external influences can cause the MS to occur in animals, but it doesn't occur on its own, right? And so when we look at why are humans, susceptible to this, well, it has to do with the synthesization of sialic acid, glycocholineraminic acid, which is a mouthful. Okay, so that gives you a little of background. When you look at research in MS, you need to understand exactly what's been researched and what the drug has been researched with. Okay, so let me give you some examples. In the future, I've written down some things that I was going to tell you about for some of these drugs about who they've been researched with, what their comparative agent was. All right, so after your diagnosis and you and your provider want to go ahead and make a choice of a medication, many, if not all of you patients have been through this. And if you're brand new to this, this can be pretty mind-boggling. Because the way your provider gives you your choices may or may not overwhelm you. So one of the things that we do is we look at a patient's general medical background and say, what is their risk profile? Do they have anything in their health history that would preclude you from using certain drugs that affect the liver or decrease the white blood cell count in patients who are prone to infections. So the first thing we do is we look at the risk profile, and then we look at the benefit of the drug, all according to the aggressiveness of the disease. Now, we're very lucky in an academic setting, and not only do we have a medical school and a residency program for many medical specialties, but we also have a pharmacy program here, and we have clinical pharmacists on staff in our department, as well as resident pharmacists that are rotating. So we find pharmacists, PharmDs, which are doctorate in pharmacy, they're a great source of education when you're wanting to look at the risk-benefit profile of a specific drug. So we try to recruit their consultative help on patients who are starting a new drug or transitioning to another drug. I can tell you what I feel personally is the absolute worst way for a brand new diagnosed patient to try to pick out a drug. And unbelievably, I have heard of neurologists in the field who do this, where they give the patient just a stack of booklets and pamphlets and tell them to go home and choose on their own. And I don't necessarily think that that's the best way to go, because now there are so many to choose from. It would add so much stress to a newly diagnosed patient's plate that I don't think that they deserve to really go through that. So here's how we go about getting a DMT, and the term DMT is short for disease modifying therapy. You might hear the term DMD, disease modifying drug. So the first part of the process is going to be the choice of the administration. How is the drug going to be administered? We have three different types. They're injectable, oral, or infusible. The next thing we're going to do, if you want to know what your insurance is prone to cover, you can look on your plan's list of medications called a formulary. If you go under multiple sclerosis drugs or under a neurology heading, you'll usually find drugs listed for each neurologic condition, such as multiple sclerosis, Parkinson's disease, what have you. If you pick a drug that is not on this formulary list, you can expect that drug to be scrutinized heavily, and there is a very slim chance of them approving it unless your provider has a good reason. The process that we go through to try to get your medicines approved is called a prior authorization. And this process, honestly, is getting more and more difficult, more tedious, and absolutely benefits the insurance companies. So, how are insurance companies attempting to control your treatment? Well, very simple. It's done on a cost basis, and they don't see you in the hospital with an IV on Solumedrol for 5 days. They see a diagnosis, and they have a code for your diagnosis, and they have a formulary list that they would like to present to you, which may or may not have anything to do with what your provider wants you to have. So let's talk about a case that would be something very, very common that we would see here. So let's say Miss Jane Doe presents to our hospital, and she's a 29-year-old female who's diagnosed with MS, and she comes to us because she has optic neuritis. She can't see in her right eye. She has total blurring vision, and for all intents and purposes, she's almost blind. And then she also has right-sided hemiparesis, which means the right side of her body moves, but it's weak. So she's in the hospital, and we've done a whole series of MRI scans on her, and we find that she has what are called enhancing lesions in 3 different areas, at least 3 different areas of her central nervous system. So when we see a patient that's this aggressive, that has multifocal involvement with enhancement, this is usually a sign of a very, very aggressive case. The problem is the insurance company doesn't quite see eye to eye the way your provider does. So they're going to try their best to make sure that you try and fail lower grade medications because of the cost. So in that case, it's up to your provider to really pick the level medication that they feel is appropriate for your condition, and then fight, if possible, to try to have that done for you. And we'll go over some techniques about doing that in just a little while. Now, one of the things that has come out recently in the past year to 2 years is generic drugs in the MS world. And if you look at generic drugs in general, one would have to say that that's a good thing. So if we look at the pro for generics, your insurance company is going to be saving money, and the system is going to save money if we can get lower cost drugs to a patient that are equally as effective as certain brand name drugs. For patients who have the opportunity, they may be able to actually afford MS medications without insurance. And I'm going to talk about that in just a little while. And then for the first time since I've been in MS care, like I said, patients are actually able to pay out of pocket for medications that their insurances stop covering. Now, why would we be against generic drugs? Well, we're against generics, and the first example I can use is the drug Copaxone. Now, patients that were on brain Copaxone, when the patent left and the generic showed up on the scene, there were many patients that were being dropped completely off the medication because of co-payment being too much and lack of any payment assistance on these generic versions. So some other examples of patients who are absolutely going to get forced into a generic situation are going to be on patients who are still on oral drugs that are brand name oral drugs where there's a generic equivalent. So we're talking about dimethyl fumarate. Dimethyl fumarate is going to be offered as a generic drug on almost every plan, along with generic teriflunomide, generic fingolimod, and generic Ampera. What did I do? All right, so that brings me to this slide. And I want folks to pay pretty close attention to this, because if you are in the situation that I just spoke about, I'll give you an example. We had a brand new diagnosed patient last year. A gentleman was in his 30s. He's an attorney. Dr. Silliman started him on dimethyl fumarate. He went through his Blue Cross insurance, and CVS pharmacy called him and told him his copayment was $1,700. Okay, so the gentleman was brand new diagnosed, got his credit card out and paid it because he wanted to get on therapy immediately. Now, over time, GoodRx had become a source where the patient could get the medication for a lot less. But now, if you look at Mark Cuban, the entrepreneur, he has a specialty pharmacy that offers an array of specialty drugs. So I'll go down the list here for you. The drug Ampera, the generic name is dalfampridine ER. On his website, a 30-day cost is $13, and a 90-day cost is $30. So if you look at the comparative cost, when the drug came out, it was $1,000 a month. So a 90-day cost would be $3,000 versus $30. All right. If you look at dimethyl fumarate, this is Tecfidera. There's a titration dose that'll cost you $14, but then after that, Tecfidera or dimethyl fumarate, the 30-day cost is under $40. The 90-day cost is $108. If you were on the medication Aubagio, this is the one that blows my mind, because Aubagio, if you look at the retail cost of the brand drug, it's probably $10,000 a month. Here, the 90-day cost is less than $30, and the 30-day cost is $12. So in essence, a drug that was $100,000, you can now get for $130. And the last one, fingolimod, which is Gilenya. This has been the toughest one, though. This has been the toughest one for a couple reasons. Number one, the cost. It is more costly than the other ones listed. It's about $300 a month or $875 if you get a 90-day supply. But the problem with fingolimod is if the patient's been off the drug for more than 10 days, they have to go through a first dose observation, and there are not a lot of places that are actually doing those anymore. So, so that would be a problem if you're on the drug Gilenya. And I want to mention something too. This really doesn't have anything to do with generic. This is even worse than generic. Okay. And I want to let people know that insurance companies are going to every length to try to make sure that patients are pushed to either generic drugs or no drugs at all, believe it or not. So I want to put out a fair warning to people. There are plans out there that look like on the face that they're insurance, and one of them is called PHS Multiplan. And we've encountered some of the most underhanded techniques I've ever seen in my 15 plus years of being here. And this is what happens is, a workplace offers this as a health plan. A multiple sclerosis patient goes to renew their medication or actually try to get a medication if they're brand new diagnosed. And what they find out is that specialty medicines are totally excluded from the plan. In other words, no matter what you prescribe, they don't even have a formulary. It's called, we don't cover it. So why are they doing that? Well, they know that these pharmaceutical companies offer patient assistance programs. And so their thinking is, if they can just categorically deny the medication, then the company's going to automatically just hand you $100,000 worth of medication. Sounds perfect, right? It's not. And what we're finding is the last bullet point is that your pharmaceutical companies are not automatically going to give a person free drug unless they have no insurance whatsoever or a prior authorization and an appeal was attempted with an insurance company and denied. Okay, so you get nowhere with a company like this, and they actually put patients at risk for getting approved on a free drug program. And I'm going to talk about what we call these people. These folks are called TPAs, or third party administrators. See, when we try to get a drug authorized, each insurance company has a separate company that does the determination. So I'll give you the best example. Blue Cross and Blue Shield owns Prime Therapeutics. So when we go to do an approval on a Blue Cross plan, Prime Therapeutics is who tells us whether the drug has been approved or not. We do this either by fax or we do it online through a program called Cover My Meds. And because there are so many generic versions of drugs now, the insurance companies are making the market utilize all of the generics before considering a brand name drug. And this first happened with Copaxone. Okay, now if a person needs to buy Copaxone out of their pocket, it's going to cost them $1,400. One of the things we always deal with at the beginning of the year is patient changing insurances. And for those of you that are on MS drugs, if you have Medicare, you may get a letter in the mail that says you've been sent a 30-day supply of your medication. Your medication's not on the formulary, and we request you speak to your provider about changing your drug because we're not going to cover it. So folks, if you get these letters, don't ignore them. Get in touch with your provider, make sure they do what's called a formulary exception. When they do that, your plan will most likely deny it. When they deny it, they need to do an appeal. And the reason they need to go through this process is so that you can get medication assistance from the company if all of this fails. We've seen some providers on the outside, some non-MS specialists, folks that just don't want to be bothered with all the hassle, just literally change the medication on a patient. And personally, I don't think that's a good way to go because your provider picks a specific drug for you for a reason. And if you've been on that drug and you've been doing well on that drug, it's honestly unethical for somebody to change you off of a drug that's working for you. And how do we know if it's working? You're not having relapses and you're not having new lesions. So it's important to understand that people who are trained in MS as a discipline look at the disease differently. Their expertise allows quick decision-making, hopefully in a direction which will stabilize the patient quickly and put them on a path of having a really stable MS treatment experience. So when you think about it, think of the analogy, and I love cars, by the way, you wouldn't take a Porsche to a Hyundai mechanic. And so think of yourselves as high-end machines that need a specialist to take care of them. So your MS specialists, honestly, their clinical acumen, their expertise, coupled with patient participation is honestly the best way to go. So remember, research studies do not study drugs comparatively among all the ones available. So it'll be the relationship that you have with your MS provider that's going to give you the best informed decision. And in my opinion, the sooner you're put on therapy after your diagnosis, or if you're in the transition to another medication, the sooner the better. Okay, and before I go on to this next concept, I just want to give you an example of some of the agents that have been tested in the past and who they're researched against. So back in the early days, back in the 1990s, when they were first doing research studies on the platform injectable drugs, Many of them were researched against a placebo. So Copaxone was researched versus a placebo. Avonex was researched versus a placebo. Rebif was researched versus Avonex. So back in the day, when we only had 4 or 5 drugs, it made more sense and direct comparisons were a lot more likely. But now that we have so many drugs available to us, I'll go down a list of some of the more recent drugs. If you look at Ocrevus, the infusion, it was researched against Rebif. Tysabri has been researched against placebo, against Gilenya, and probably against an interferon drug back in 2005. The drug Kesimpta, the injectable drug, was researched against teriflunomide, which is Aubagio. Zeposia was researched against Avonex. And then drugs like Ponvory were researched against teriflunomide. Now, why is this significant? It's significant because in these research trials, you can only make a determination based upon the drug it was compared to. So if you have 16 drugs, you can see how difficult it is for your provider to know if a specific drug is going to be more effective than the one you're on, given these research comparisons. So what do we strive for in MS care? The gold standard in MS care started back when Tysabri, natalizumab, a very high efficacy infusion therapy. There was this concept that came out after that drug had demonstrable success in stabilizing very aggressive conditions of MS. And they came up with this concept called NADA, which is no evidence of disease activity. So if we get a brand new diagnosed patient and we can get them on therapy from the very beginning, theoretically, NADA is a concept that we want to get a person to, and it would be commensurate or comparable to what we call remission in cancer care. All right. So what NADA refers to is no relapses, no increase in disability, and no increase in lesions. Now, there is a fourth component that's sometimes added, and that has to do with brain shrinkage or atrophy. So is this concept always attainable in patients? And the question is, hopefully. We hope to get a patient on a drug that works for them and prevents these things from happening. But if you do have a breakthrough, meaning you have relapses or increase in lesion activity, then these would be clinical reasons for your provider to consider doing a switch. Now, some of the last things I'm going to talk about, because all MS patients want to know what's new and on the horizon. So you're going to hear a lot of buzz about these drugs that are coming out that are called BTK inhibitors. And BTK stands for Bruton's tyrosine kinase inhibitors. So all of the drugs that you're going to see coming out are going to have the last 3 letters or the suffix NIB, NIB, and this refers to the inhibition of the tyrosine kinase. It's an inhibitor for that specific agent. So as we go through this, I'm going to talk about these new agents very briefly. Now, for all of you biochemists out there, this probably is a very simple diagram, but for all of us folks who are pretty simple-minded, this could be pretty overwhelming. So what we're looking at is the mechanism of which these medications, and you'll see them highlighted on the right here, evobrutinib, orelabrutinib, tolobrutinib, remibrutinib, and then the last one, fenebrutinib. So these drugs you're going to see probably coming out in the future. And what these do is these work on one of the mechanisms that is assumed to be a factor in the ongoing inflammation of MS. So evobrutinib is the one that's been mostly studied, and they have research results that have come out, which I'll talk about briefly. Tolobrutinib is the second one, remibrutinib, and orelabrutinib. So all of these studies, with the exception of evobrutinib, are still in process. The conclusions of these studies is that they've kind of looked at a new mechanism of study by looking at B lymphocytes and myeloid cells. So myeloid cells are cells that arise from the bone marrow, and these are thought to play a role in the chronic inflammatory process of MS. So all of these new BTK inhibitors are drugs that are going to be used to target certain processes within the way that these B lymphocytes and myeloid cells work. All right. So they're currently researching 4 of these 5. Now, recently, as of December, the results came out, and unfortunately, what it showed is that evobrutinib was comparable but not better than the existing drug teriflunomide. Okay, so that's Aubagio. So that is not an encouraging finding, but it's not a final finding because there are other studies that demonstrate other things. So that's what you're going to see and hear in the MS world when it comes to, some of the new mechanisms that they are trying to develop to attack the ongoing inflammatory process of MS. And very last, I want to go ahead and just mention that in the beginning of the year, the staff in the offices, the neuro offices, the MS practices, that patients should understand that, your office workers, the staff of the medical offices, they do a lot of work behind the scenes that patients don't really know and understand. And these prior authorizations are becoming very complex, and the insurance companies are getting very, very difficult when it comes to getting these high-level things approved. So MRIs and high-level MS therapies are expensive. And the timelines that the insurance companies use sometimes is very challenging for us. We have patients that need drug, and sometimes the insurance companies drag it out unmercifully. All right. So remember that utilize clinical pharmacists as a resource if you have the opportunity, because they are the ones who are educated in medications, and we find them to be a really valuable resource in our MS team and our MS program. And the last thing I will tell you as a patient, be on top of your prescription dates and know when your renewals are needed. And every year you want to make sure that you update your insurances with the medical office, because we have patients that are amazed they're out of medication when we don't have their new insurance. So believe it or not, it doesn't happen magically. It is a process, and we appreciate your cooperation as much as possible. And most of all, I appreciate the opportunity to be with you all today. And I'm going to conclude with any questions if anybody has any.
Wow, that was wonderful. Can you hear me, Dr. Chaifetz?
Oh, yeah,
Okay,
absolutely.
good. Because our internet in the building is somehow not working great, but I'm glad you can hear me. That means everybody else can hear me. So let me at least let me go at least help. For those people that have not been with us before, I'm going to give them some directions as to how to submit their question. If you have any question or you'd like just to make a comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you choose. Or you can just ask your question live by raising your hand. And then what I would do is just you would click the raise hand button, and then I'll just go ahead and unmute you. Or you can just press *9 if you're on a phone. So let's do that. As of right now, your presentation was so thorough that I don't even see any questions. So let's see.
I,
I mean, seriously, I
I
normally have a
hope
ton of
people
questions.
aren't just scratching their head going, I can't believe this BTK diagram. I'm still trying to process it.
No, seriously, so much information. That was awesome. Let's see. Can you stop sharing your screen? Is that possible?
Yeah, let me do that.
That way we'll be able to see your whole face.
Yeah, there we go.
Okay, good. Let me see if I'm gonna try to do this.
Thank you, Sarah Modrick, who said that was the best presentation I've seen from this organization. That was an awesome compliment, and I appreciate that, Sarah.
That really was a really nice compliment. Sarah, that was really nice. Okay, and it was amazing. Amazing. So, okay, let's see here. Let's see here. Well, normally if there's a question that I don't see up there, then I then I go ahead and start jotting things down.
Yeah,
What's the difference? Tom wants to know what the difference is between Tysabri and Tyruko.
oh, okay. Great question, Tom. Thank you for asking. So in the oral MS world, we call generic drugs generic. In the infusible world, we call them biosimilars. So probably Tyruko is the generic equivalent to natalizumab, which is Tysabri. So if your provider is good with the drug, you should be fine. If
Great.
you're just starting the drug, you should be fine. So you really shouldn't have any trepidation if you're in a situation where you have to go from brand Tysabri to the Tyruko. But that's probably the best answer I can give you. How's
Okay.
that sound? Great.
Good answer. So we have an anonymous attendee who's asking, what is your feeling about older 60 plus aged MS patients going off of DMTs after MRIs are stable?
Well, that's going to be between the patient and the provider, but I will tell you that I've worked with neurologists who have taken patients off of drug if they hit the secondary progressive non-active phase. And the way that they would do that is just continue to do MRI scans every 6 months to a year, possibly, to make sure there's not activity. And if that goes on for a period of time, several years, then a lot of times there's, inherent stability if the person's had the disease for a while, because it seems to quiet down a little bit, the longer a person has it.
Thank you.
Yeah.
Are there any studies being done comparing glatiramer acetate and teriflunomide?
I'm surprised there aren't, because it seems like teriflunomide, which we call Aubagio, I always, the comparison I use is that, imagine there being two armies, right? And you have America, the United States Army, and you're going up against another army. And some of the comparisons, and I won't say which drugs, it's like the Russian army going against Barbados's army. It's not really a fair fight. And so the comparison's going to come out obviously in favor of the drug that it's being compared to, because that's what the whole intent of the research was. So until we start seeing more comparative research trials, like 5 or 6 drugs compared at a time, or all of them compared, which would, when you think about it, would be almost impossible because of cost, number one, and logistics. So going back to what I said initially, your provider's experience has a lot to do with the best choice for you. And that's why it's good to see somebody who is an MS doc.
Thank you.
What is,
And Carrie has an interesting question. How can you evaluate someone's MRI findings well with new symptoms if they're having spasms in the MRI machine causing movement and also are allergic to gadolinium?
well, okay. So if they're allergic to gadolinium, they may be able to use a different contrast. And even if the person moves, lesions don't. So it's one of those things where, either the study will be diagnostic, which means readable, or not readable. So if they've read it, then they're able to discern a certain diagnostic component to it.
That makes sense. Okay.
Yeah.
Tiffany would like to know, are you aware, she's asking, are you aware of which drug Briumvi was researched against?
No, I'm not actually. I didn't Google that one. Let me look real quickly. Um, no, but I wouldn't doubt if it was researched against like Aubagio or an injectable Avonex or something like that.
Okay.
Yeah.
What's your opinion on infusions for treatment?
Well, infusions for treatments are considered to be somewhat of the top shelf level of treatment, meaning for the more aggressive cases. So depending on how aggressive the patient's MS is, what previous disease modifying therapies they've tried and failed, those are factors in determining whether a person wants to go to an infusion therapy. Never make a decision on commercials on TV.
Good point. What has your experience been with patients on Aubagio? Are liver problems minimal?
Yes, liver problems are minimal, and that's why before we start a person on teriflunomide or Aubagio, we do liver function studies for 6 months in a row, and we do some other studies too to make sure that there isn't any liver disease before the person goes on the drug.
Great. Can MS patients stop taking Gilenya if they're in good health for many years?
Well, that's a difficult question to answer, which I can't do because I'm not your provider. But the only thing I would tell you is maybe the Gilenya is helping you stay good for many years.
Hmm, makes sense. Okay. How do you feel about Kesimpta?
Kesimpta is a really excellent option in the class of medications that it's in, which is it's a CD20 depleter, which means it's an immunosuppressant. So for patients who are prone to infections, it may not be a good choice. For patients who want a CD20 depleter, and other ones include Ocrevus and Briumvi, but they don't want to go to an infusion center, it's an awesome option for home self-administration.
Okay. And we do have time for one more. So I'm going to go ahead and this is from an anonymous attendee. What about the patient that was diagnosed at 59, but had been
Okay.
having symptoms for at least 10 years prior to diagnosis and is currently receiving a DMT? do you think they can stop taking the meds in their 60s?
Well, I wouldn't recommend it on your own. That's a decision you need to make with your provider. And once again, if you've been steadfast taking your meds and you're doing great, I mean, depending on the cost of the medicine, if you're having side effects, if it's affecting your organs like your liver or what have you, there's a lot of factors that go into completely stopping a medicine. Uh, it- Discuss it with your provider. If he feels like he wants to take that chance with you, just make sure that they're screening you periodically to make sure that you're not progressing.
Thank you. We do have one more. Do you have a chance to,
Yeah.
or do you have to run? Okay, so
So infusions for secondary progressive and older people, we have many patients in that category. So once again, if your provider feels like you're still active in secondary progressive mode, then yes, there are a lot of options out there for you.
wonderful. Okay, I
Well,
think
thank
that's it.
you.
Yeah, that brings us to the end of our time. If you've missed any part of this conference, it has been recorded and it's going to be available through the MS Focus Facebook and YouTube channels. Reply to your registration email for information on how to access the recordings or to just to sign up for our newsletter, which is going to tell you about all the upcoming events. Our next teleconference will be Friday, February 9th at 3:00 p.m. Eastern. In honor of Black History Month, MS Focus will be hosting a 60-minute three-person panel discussion spotlighting the Black MS experience. All three of these panelists are living with MS. And in fact, can you see me? Because I don't know if my camera is working. Are you able to see me?
Yeah.
Okay, good. So this is the book that we created a year ago. And if anybody wants this, it's a fabulous book about MS in the Black community. All you have to do is respond to your email reminding you of this program today. If you respond that you'd like one, we can go ahead and mail it out to you. We'll talk to you about how to do that. So just send us your physical address in the email and we'll go ahead and send one out. It's a great booklet. So as you leave the conference today, a survey will appear on your screen. We ask that you take just a moment to give us your feedback on the program and your suggestions for future topics. We want to make sure that we give you, the best and the most meaningful programs. Our sincere thanks to all of our attendees for your participation and especially to Dr. Chaifetz. That was an amazing talk. Thank you so much. The presentation was so factual, yet I think everybody got it and understood it. Thank you very much for your time and the fact that you take your time out of your day to do this for us whenever we ask. We just love it. Goodbye, everyone, and we hope to see you all again soon.
Thank you.
Toodaloo.
Have a great day. Thank you.